Okay, thank you. I think we're all but at 9 o'clock, so we'll kick off and welcome everybody to this meeting of Herefordshire and Worcestershire Health and Care NHS Trust. I think it's very apt as we're in National Mental Health Week to have our public board meeting in this week. Can I welcome a few people, although it seems a long time ago now, but nevertheless, this is our first public board meeting or meeting in public of board since Rob as the Chief Executive, John as our designated Deputy Chief Executive, and Denise as our Director of Finance. So you're all welcome to your first public meeting in your new references. And also I'd include in that Veena as a full non-executive director. I think this is your first public board meeting. So welcome everybody. There's also a number of guests that have joined us for a variety of reasons. I know a number of guests have joined us from within the organisation as part of their own development and knowledge gathering. If any of you have any questions following the meeting, then anybody on screen from the board, including myself, will be more than willing to discuss any matters of this meeting with you if it would help you. We have a busy agenda today, so I'd ask, as ever, all of you to try and respect the timeframes that we've tried to give. We'll try and get done. I think it's by 12:30 we should be finished, and I will build in some breaks. I have, for your information, I have accepted. In fact, I think it's fair to say I was the one that put it there, and any other business which will be taken towards the end of the meeting, and it's been taken because it's something that's come up only in the last few days, and this we didn't want to leave it for another couple of months before we have another public board meeting. So with that, we'll move on to any apologies. I've received apologies from Sue Hinks that's got alternative business elsewhere, so Sue can't join us. Do we have any other apologies that I've missed, Jill? No?
No,
okay.
We don't.
Thank you very much. If we then move to our minutes of the meeting on the 21st of March, can I ask if there are any matters arising or any matters of accuracy? It's the easiest way to do it, say, rather than page by page. Anything at all? Any hands? No, in that case, we'll take that as a true record, an accurate record of the discussions and the decisions at that meeting. Thank you, Jill and your team, for doing those again. Very good, thank you. If there are no matters arising, we've then got the action log, of which there are two actions on there, both to Matthew and both complete. I'll take one at a time. Matthew, the guidance has now been received on talking therapies and clarity obtained. Perhaps you could just remind the meeting what the clarity was and if there's anything else we need to know.
Sorry, Mark, struggling to get off mute. Yes, the clarity was how the target for the coming year was going to be set. So the previous target was around people accessing talking therapies, so contacting talking therapies and requesting an appointment and being assessed. The new target is on people having completed a course of treatment. So that's having gone through talking therapies and received 2 or more contacts from the service. So we've got a new target set, and that target will form part of our National Outcome Framework indicators.
Thank you, Matthew. And the other one, there's a very full explanation in our action log with regard to the route to CAMHS for the children that are homeschooled. So I don't think there's any explanation there, but thank you for obtaining both of those clarifications. If there are no matters arising from that, we'll then move on. And Jill has informed me that we do have a question from a member of the public. So I assume Jill will read the question, and I believe Sue might give an answer. So Jill.
I was going to deal with both, actually.
Okay.
So the question, first of all, there's a little bit of context. The Trust has invested £93,000 of public funds into the Worcestershire VC SE Alliance. The lead officer in the Trust was Sue Harris between April 2023 and the 30th of September 2023, and Carol Camino held the VCS Alliance role exec lead pending the recruitment of the subsequent strategic lead. This was a position she held concurrently with her recruitment as a NED of the Trust. I do need to put some context in there. That's actually incorrect because Carol wasn't appointed as a NED of the Trust until the 7th of November. The requester then goes on, in the summer of 2023, he raised concerns with the lead officer and their counterpart in the ICB and the chair of the VCS Alliance, Peter Sugg from Young Solutions, about a number of issues with the Alliance. He was given assurances that he should not be concerned. And then the three questions. Does the Trust Board consider that their investment of £93,000 of public funds in the Worcestershire VCSE Alliance has accrued the benefits anticipated in the investment appraisal or business case for the Alliance, and if not, why not? The answer is this was a one-off investment from NHS England that was made pre-COVID to fund engagement initiatives across the system. The funds were hosted by the Trust. NHSE approved the use of the funds to implement the national requirement to embed the VCSE in local integrated care systems, which is how the sum was used. The second question is, who or what is accountable for the actions of the VCSE Alliance Management Group? And the answer is the Trust cannot answer this question. The VCSE Alliance is a collaborative of sovereign organisations with their own individual governance. And the third question is, does the governance arrangements of the VCSE Alliance adhere to the Nolan Principles? Again, the Trust cannot answer this question. The VCSE Alliance is a collaborative of sovereign organisations with their own governance. The Trust has no oversight or regulatory role relating to them. Those are the questions. I'll ensure a written response is provided. You're on mute, Mark.
It's nice to get that out of the way early, isn't it, to save doing it halfway through the meeting. The requester will get that all in writing, Jill, yes? Right, thank you very much. If we then move on through the agenda, declaration of interest. As always, if any new declaration of interest come up, then please ensure that Jill has them and we publish them on our website so everybody can see what they are. Okay, we now move on to patient story, slightly different this time around, and Natalie will explain that difference and give an introduction. Natalie.
Thank you, Mark, and good morning, everyone, and welcome Lucy and colleague who are here from our Worcestershire Perinatal Mental Health team. So, as Mark's described, a little different this morning, as we have a patient who wanted to remain anonymous and wanted to share their story with us, but as I said, has done so outside of this board meeting, but all of board have observed the recording that we made. So I'm going to call her Kirsty for her anonymity and just briefly talk you through it, then hand over to Lucy so she can tell us about the service, and then we can have any questions that people may have. So Kirsty, as I said, was under the service of the perinatal team in Worcestershire. She is a mum to a little girl. It's and just one little girl. She has experienced some mental health challenges previously in her life, but has made a good recovery, and then got pregnant. Very quickly, she experienced something called hyperemesis, which is an extreme form of nausea and vomiting in pregnancy, and that lasted throughout her pregnancy. That's really key because actually the impact that had on her mental well-being was significant. She felt incredibly poorly all of the time, and she really connects that with her initial feeling very low in her mood. She then developed a really fixed belief, and she describes it as clear as the sky is blue, that she was going to die in labour. She had a very clear perspective that that was going to happen, and therefore she made clear plans as to what would happen following her death. That belief was absolutely solid and remained with her during her pregnancy. She was referred whilst pregnant to the perinatal team, but at that point didn't need their services. But then after the birth of her daughter was re-referred, a midwife who she describes as being incredibly kind, clearly said to her, "You are not well, you need to be seen," and another referral was made and accepted. So Kirsty was then under the care of our perinatal team, and she describes being seen by a number of staff from that service. She found the input of all staff really valuable, but she really warmly talked about the nursery nurse and the peer support worker. People are giving her really good practical skills. First time mum's hard for anybody, but when you're also feeling very anxious and depressed, that's even more difficult. So describe their value. Again, peer worker isn't the first time that's cropped up in a patient story, and about how finding another mum a bit like me and the understanding that individual has is absolutely invaluable. She also had services from the nursing and some therapy called EMDR, which again she described as really valuable. Kirsty also wanted to talk to us about that recovery isn't linear, and we often think you start poorly and then you get better and then you get discharged, but her recovery is much more fluid than that. And so we talked about endings of a service. So, and Lucy will describe from the service about why the perinatal team sees you for a certain period of time, but then what happens after that. And certainly some clarity Kirsty thought about endings and thinking about discharge from certain services and what happens next. She also, her other reflection was at the very start of her service with us, she wasn't clear what was happening to her. So people had talked about anxiety, but she would have preferred a much clearer diagnosis, but equally understands that was early days and people were still formulating thoughts and ideas about what she might be experiencing. So that's a summary of Kirsty's story. If there's any questions, happy to take them now, but actually also hand over to Lucy, if that's okay, Mark.
Yeah, if I could just add a little context for our guests who have not seen the video, and for anybody that's watching online either now or subsequently. The video that all board members have seen was basically Natalie, our Chief Nursing Officer who's just spoken, chatting to Kirsty about her experiences, and that chat went on for 25 to 30 minutes, quite extensive, and it's fair to say that Kirsty was extremely articulate and extremely sort of honest and forthright about her own condition, and it was perhaps one of the most powerful things you could watch for a 25-minute to 30-minute period. So that's just a bit of context for those that haven't seen the video, Natalie. And I think, did you say now handing over to Lucy, was it?
I'll introduce you to Lucy.
Yeah, that's fine. Hi, nice to meet everybody. I'm Lucy. I'm the clinical lead for the perinatal mental health team. And I also have a colleague with me today who actually worked with this patient. She's our CBT EMDR therapist. So she's going to sit in and join us. I've got a presentation I'm going to share if that's okay, but I'll try not, I'm not going to read off the slides. Let me just share this with you.
Lucy, we've got a tiny bit of background noise from your colleague, I think. Are they on the phone? We can hear.
Yeah, bear with me 1 second. She's just going to end her call. Sorry, she's just taken an urgent call that had come in.
We understand you're in a shared office. It's absolutely fine.
Can everybody see that okay?
Yes, we can. Thank you.
Lovely. Okay, so obviously we're the Worcestershire Perinatal Mental Health team. There's also a perinatal team over in Herefordshire as well. Today I'm just going to introduce the team to you, tell you about the different roles within the team, the sort of patients that we're working with, how long we're supporting them, the interventions that we can provide, a little bit about kind of the referral criteria and the mental health conditions that we're working with, and then kind of where, if we, when people are discharged from our service, where they might go to following the discharge. So yeah, this is a team. This is actually quite an old picture of the team. We have grown quite a lot in size since this picture was taken. We were very fortunate to have an uplift, to receive some money and some funding towards recruitment. So in the past year, we've introduced some new roles, brand new roles to the team. We actually have, it's not on here, but we have a nursing associate who will be joining the team to focus on kind of the physical health of the mums that we're supporting. So she'll be running physical health clinics. So that's a really exciting role. We've also been able to increase our psychology provision. So we have new psychologists within the team. We had a period of time that was very challenging. So I would say for the past kind of 2 years, we've struggled with recruitment, which has never really been an issue for our service historically. And we had a couple of members of staff either leaving, and we had people off sick for a long period of time, and we were really struggling to recruit into those posts. We've also found as a service, kind of post-COVID, we've been the busiest we've ever been. We've had more patients presenting in crisis kind of situations, and our caseload has increased significantly. So as you can imagine, the team have been under a lot of pressure. We are now at a point where we have a full team, which is really exciting. So yeah, that's just a little bit of an overview of the team. Obviously, I know in the story spoke about the peer support worker, who is actually a lady who was under our service, was supported by us as a patient, and is now has a permanent post within the team. And she's obviously a very valued member of the team. We have nurses within the team. Psychologists, we have quite a new role, an assistant psychologist. We obviously have an EMDR and CBT therapist, who's Caroline, who's sat next to me. We have a trainee advanced clinical practitioner who's currently kind of spending time with the team 1 day a week. But the hope is that eventually we'll be able to make that a permanent role within the team. We have nursery nurses who support with things like bonding and attachment and practical things around caring for baby. We have an OT who we're hoping to put through some sensory training, because we're finding that we're getting an increasing amount of referrals for mums with neurodiversity, so ADHD, autism. And then I think we have the psychiatrists and our medics, and obviously me. So that is pretty much an overview of the team. So the perinatal period, historically, we worked with mums and families up until baby's about 1. But actually, that's now being extended. So we're working towards 24 months. So that's quite a big change. It was recognised that actually mums, family members struggled a lot longer after baby was born. So people were presenting sometimes later than 12 months with kind of mental health difficulties. So yeah, that's now been extended, and we are working towards that, although we're not quite there yet. What I will do is share this presentation after, if that's okay, Natalie, just so people can have a look. There's some videos on there and some resources, just if people wanted to go and kind of look into this a little bit further, but you can see some useful sources for more kind of perinatal information. So we are working with mums who are struggling with moderate to severe mental health difficulties during that perinatal period. So from pregnancy up until eventually 24 months. So we may be seeing people who are presenting with kind of moderate to severe mental health difficulties for the first time in the perinatal period, or we might be working with mums, families who have long-standing mental health difficulties, but actually those have been exacerbated during the perinatal period. If people have kind of long-standing mental health difficulties and they become pregnant, we will often get a referral for them. But actually, if their mental health is kind of much the same and it hasn't kind of got any worse, I suppose, during pregnancy or that postnatal period, then they would probably be more suited to the neighbourhood teams, or they may already be under the neighbourhood teams, and it might be that we do some joint working. So in terms of kind of referrals, we accept referrals from GPs, midwives, health visitors. That is where the majority of our referrals come from. Then we will get referrals from maybe other specialist teams, so it might be EI or eating disorders, and then we will get referrals from neighbourhood teams too. We are starting to look at actually where else we can get referrals from, so we are starting to accept referrals from services like Becoming Families. They are essentially a charity in the community who are pretty much made up of a similar team to ourselves, but they also have like specialist midwives, and they have psychologists in the team, and they work closely with sometimes those mums who are lower level, so they might not be kind of in that moderate to severe category, but we are starting to kind of open up referrals from those services. Generally, they'll be sent by email, or people might call us and talk to us about referrals. We obviously also get urgent referrals, and that might come from all of the services I've just talked about, or it might be from the crisis team, who may pick up sort of more urgent referrals out of hours. It might be the mental health liaison team or the home treatment team. We also screen referrals for well women, so women who have a history of bipolar disorder or a previous episode of psychosis, or they have a first-degree female relative who has had psychosis or bipolar, because that places them at higher risk of becoming unwell in the postnatal period. So yes, so this I've kind of covered all of this already, but generally we're working with mums with moderate to severe mental health difficulties. Because of the increase in referrals, we've kind of had to be a bit tighter in terms of what we're accepting, and we now have access to other services, charities in the community who are doing some brilliant work with mums, families, partners in the perinatal period who we can now refer to, as well as talking therapies, which I'll talk a little bit about towards the end. So as I mentioned before, we will be working with mums who have a past history of severe mental health illness, or a first-degree female relative who has bipolar affective disorder or has had psychosis. We normally, I would say, we kind of get a high level of referrals for women who might have been under our service before. So obviously going into a subsequent pregnancy, there is that risk that they could become unwell again. So we might be working with people who've kind of accessed our service previously. We might offer preconception counselling to maybe women who are taking certain types of medication, who want to get pregnant, and they're concerned about kind of how their medication might affect baby or pregnancy. So we offer that as a service. We will also offer assessments for people if they are wishing to seek a diagnosis of tocophobia, so a fear of childbirth. We are only working with people who have care of their child. And then we might be seeing women who are presenting with difficulties kind of around bonding with baby. So just a little bit of a note. So why is it important that, you know, the perinatal team exists, the specialist perinatal team? There's the Embrace UK report. Obviously, I'm not going to go into all of that today because it's a big report around maternal mental health and deaths. So 40% of deaths within the year after pregnancy were for mental health related cases, and suicide remains the leading cause of direct maternal death in the first postnatal year. Suicide during pregnancy or up to 6 weeks after is increasing, as you can see here, the figures there. Very few women who die by suicide in 2020 had a formal mental health diagnosis, but significant numbers had a history of trauma. I'm not going to go into all of this, but it's just to give you an idea of sort of what we're working with. So we are working with mums with a variety of different mental health difficulties. So it may be depression, anxiety, OCD. We work with mums who've experienced kind of significant trauma in the past, or maybe birth trauma. We will work with mums who have maybe had postpartum psychosis previously, which is, you know, a medical emergency. That's our kind of bread and butter, I suppose. So, and I'll just talk a little bit in a moment about postpartum psychosis. So, as I said, it's a medical emergency. 1 in 2,000 births. It's an unusual presentation. So somebody will be presenting with similar symptoms as psychosis, but it can be quite a kaleidoscopic presentation. So they may kind of acting differently to how they normally would. It's normally in those early days after birth that people are at higher risk of developing postpartum psychosis. And if somebody is referred to us by midwife, health visitor, GP, we would go and see them pretty much straight away to assess them. Yes, so in terms of management, it's really important that they're seen almost straight away, and it usually, unless we capture it very, very early on, will result in an admission to a mother and baby unit with baby, because in terms of recovery, if mums can stay with babies, it makes a difference in terms of how successful their recovery is. So the red flags around kind of postpartum psychosis are new, disturbing or anxiety-provoking thoughts of suicide or harming self in violent ways. They might be having thoughts of harm towards baby. They might be struggling to sleep. They might be saying that they don't need to sleep and they're awake for days on end. New and persistent expressions of incompetency as a mother or estrangement from infant. And then they just probably a lack of awareness about how poorly they are. I've mentioned already the other perinatal mental health conditions that we're working with. So in terms of what doesn't meet our criteria is the low level anxiety and depression, even if related to the perinatal period. And as I've mentioned, there are some brilliant services that we work very closely with. So Becoming Families, Nurture Families, Home Start. They offer support for mums and partners now in the perinatal period. They have access to psychology. They have midwives, so that's support during pregnancy and postnatal period. They offer groups. So a lot of what we can offer, but it's for that lower level kind of mental health difficulties. I've already mentioned about kind of the community teams, and actually if there are long-standing mental health difficulties that haven't been exacerbated in the perinatal period, they would work with those mums. And it might be that we do a bit of joint working. So if they're working with those teams, they might be doing psychology with those teams. But then in the postnatal period, they're struggling with things like bonding or maybe accessing groups. There's anxiety about groups. We would offer groups to them so they could attend our groups. And it might be that our nursery nurses do some work around bonding with them. And as I've said, we don't work with women who do not have care of their baby. In terms of groups and interventions, there's a long list of things here that we do and that we offer as a service, and this is changing all the time. We offer a huge range of groups. We're starting to introduce new kind of psychology-based groups, so CBT and compassion-focused therapy. We offer things like yoga, walking group, an antenatal group. We're now starting to do more work with partners. So we have a partner support group set up, and we've just finished developing our partners pathway, which is really exciting because we recognise that actually partners and that wider support network need the support during that period. And we are seeing an increasing amount of referrals for partners who might be struggling with things like postnatal depression or maybe trauma around the birth and things like that. So that's a huge benefit. I'm not going to read out all of these interventions, but it's just to kind of give you an idea of what we're offering as a service. And then signposting, so it might be that when somebody comes to the end of their time with us, it's obviously a very anxiety-provoking time. As a specialist service, the patients that spend their time with us, they generally spend quite a long time with us, and so it's a really scary prospect. But we now have, thankfully, to our wonderful peer support worker, she's linked us in with lots of services within the community that we can refer on to, and also talking therapies. We've now built a really good relationship with them. We have a perinatal champion, Within Talking Therapies, we have our own perinatal pathway within Talking Therapies. She attends our weekly MDT meetings, so it means that those referrals that don't quite meet our threshold, they can then pick up a lot quicker, and because of the perinatal pathway, those referrals get expedited and they're seen a lot sooner. And that's not just for the mums, that's for partners also, so that's really positive. And we also have very strong links with health visitors, midwives, who we work quite closely with. So that's it. I'm going to stop sharing. I hope I've kind of given quite a good overview. I'm sure you've got some questions that you might want to ask. So thank you for listening.
Thank you, Lucy, for the explanation, and also thank you, Natalie, for the video and the manner in which you interacted with Kirsty to allow her to tell her story was great. Okay, if we move on now, I've got Janet and then Martin, please.
Thank you, Mark. Thank you, Lucy, and thank you, Natalie and Kirsty. I think both presentations, the video and the presentation we just had, really worked together very well, because I had quite a few questions after watching the video, and actually, Lucy, you've answered them. So I feel that's worked extremely well for my understanding of the service. My question is, I suppose it's a bit of a concern, really. It's obvious we can see the good that you do and the impact that you have on our patients, which is really important. But you mentioned the fact that actually your remit's going to be expanding for to 24 months after birth, and you also mentioned the fact that means you're having to tighten up your acceptance criteria, and I suppose I would be concerned about that, and I'm just wondering if you've got any views on how we can mitigate the impact, please.
Yeah, absolutely. So as I mentioned before, I would say in the past 2 years have built really good relationships with those services out in the community that are offering a similar kind of offering to ourselves, but maybe for those lower level patients. So what I would say, just to give a bit of context, is that historically we might have accepted sometimes kind of low to moderate patients, whereas now, because we have those fantastic services in the community that we're working really closely with, who can offer psychology, a lot of the things that we can offer, they can then go on to those services. And the same with Talking Therapies as well, because we're working so closely with them, and we're discussing all of the referrals that come in that meet maybe more of their threshold. It means that we're working more now. We're not picking up sometimes those low to moderate patients. I would say more so the lower patients, the lower level patients that we would have picked up before, because we've got some brilliant services that we can signpost them to, if that makes sense.
Yeah, Martin, and then after Martin, John.
Yeah, thank you. Sorry, my question's in a similar vein, but it's also around some of the language we're using, which I think came across quite strongly in the Kirsty video, that some of the words we're using around discharge and thresholds really are very medically focused, clinically focused ones, and not very patient focused. Mm-hmm. And on the course I had yesterday around A Kind Life, one of the senior managers said, yeah, what it's made me think about is I'm a manager of people, not a manager of services. And I think too much we are managers of services, not managers of patients and their pathway. And I just wonder if there's something we need to be thinking about, not just in relation to perinatal, but it pulls out that language we're using with our patients about we shouldn't be using discharge, we shouldn't be using thresholds, we shouldn't be using your low to moderate services there. How do we build that continuum for them, particularly with mental health, that we're not falling into the language of more acute care of being discharged from hospital, because actually a lot of people with mental health conditions are on a continuum that shouldn't be discharged. And that's where I thought some of the real anxiety came through in the video around these discharge moments rather than continuum of care.
Yeah, thank you for that. That's really good to hear. I suppose the service, we're all trained in our team in compassion focused therapy. We are, I mean, obviously I'm the manager of this team, so I will always shout about how great my team are, but we are a very, very compassionate team. What I would say is that it's not, we don't kind of say to patients, you're being discharged. It's not like that at all. Obviously, I'm using it here just to kind of explain the process and things, but generally that's not a term that we would use. And again, we wouldn't kind of talk about threshold and things like that. But I do think that is a really good point, and I'll definitely take that on board and have a talk to the team about that and how we can, move forward with that. But I would say generally on the whole, they're not terms that I would use with patients or that the team would use with patients.
I think we would use things like transferring to GP care rather than discharge from our team. So it's, like you said, part of that journey, I suppose. So when I'm discharging patients, I would usually say, we'll transfer you back to the care of your GP.
Yeah, I think it's got a wider application, and this referral process that we talk about is quite, I think, it breaks up the patient journey rather than continue. I haven't got an answer, but I think it's something we should look at across our services. Thank you.
Yeah, definitely. Thank you.
John.
Thank you, Mark. Just to come back first to Martin's query, I think we probably need both. We need care pathways, both operational and clinical, just to make sure that we provide standardized care, effective evidence-based care. And that's something probably, it's for staff and professionals to know what to do, when, etc. But what personalizes it for the patient is the individual care plans. And the language used in individual care plans would be exactly what Lucy and her colleague were saying. It's transfer rather than discharge and so forth. So I think we need both and use it appropriately. My question, Lucy, thank you for your presentation. The birth trauma inquiry report has been in the news recently. The experiences of women who experience physical harm, but I'm sure there's a mental harm as a result of that. Do you provide at the moment services for that as well? Can you tell us a bit more about that, please?
Do you want to talk about it? Caroline's our EMDR CBT therapist, so it's part of your role, isn't it, to deliver?
Yeah, and we also do quite a lot of kind of care planning, sort of trauma-informed planning as well, particularly for women who have had a really traumatic pregnancy the first time. When they're going on to have subsequent pregnancies, they may come to us about that. So we do a lot of work around, working with midwives and the obstetric team around planning births and subsequent pregnancies, so the women feel much more in control of that and much more empowered in that process.
We offer trauma therapy, so EMDR, and we also have a service that sits alongside us, Beacon, the maternal mental health service. And they can also offer therapy around birth trauma as well. So there's a little bit of a crossover in that sense. We would probably be seeing those mums who've experienced birth trauma who are having kind of moderate to severe mental health difficulties as a result of that. So they're struggling to function. They might have moderate to severe anxiety or depression, and maybe the risks might be slightly different. If it is just around birth trauma, and it's a really clear PTSD, it might be that actually Beacon, the maternal mental health service, might see them. But again, we work very closely together. We attend each other's meetings, so we discuss those referrals that come in around kind of birth trauma and trauma.
Thank you, Lucy. Two further non-executive directors got questions. Veena first, and then Beej.
Thank you. I just wanted to pick up on the point that Martin made, and I totally take the point about language. But actually, Matthew and I had the pleasure of spending some time with your team earlier this year. I think we attended a team meeting, and we did the same with the Herefordshire team. And I just wanted to make the point that we could see that there's an awful lot of pressure. You're overstretched. I think at the time you were understaffed. There's an increased demand for your services. The facilities aren't always fantastic, and yet I have never seen such an energized and compassionate team. And I would say the same for your Herefordshire colleagues as well. And I actually wrote down at the time, one of your team members, a CPN, described her role as the best job in the world. And that was amazing to hear, really, really amazing to hear. And I think on the day I described you guys as one big married couple, because you were even finishing each other's sentences. So please don't think that anybody is saying that there isn't compassion in the team, that there's buckets of it. And I just wanted to publicly acknowledge how impressed we were about that.
Oh, thank you, Vina. That's so lovely.
Beach.
Thank you. Thank you, ladies, for the presentation. That was fantastic. And thanks, Natalie, for the video. I don't know whether I should call it out, but there was a lady, I think, mentioned in the video by your patient. I think that was Tash. It was very clear that Tash has done a fantastic job working with this patient. Things like, she gave me belief and confidence. She made her believe that I'm a good mum. These things are really important in the circumstances that your patient was sadly going through. So, a big shout out to Tash, because she was an important part of this patient's journey. There were questions, Natalie, you posed around, do you feel like you're being listened to? And what I heard as a response was, I need more. I feel lost at the moment. I'm signed off, but I'm feeling like my treatment isn't complete. I still don't know what was wrong with me, and I still don't fully understand. So I'm reflecting on that and thinking, what sort of learnings do you think, Lucy and Kirsty, but also Natalie, what sort of learnings do you think this particular, albeit just one small case, gives us about how we can make sure the patient's voice remains central to everything we do when we're thinking about their journey?
Want me to jump in there, Lucy? Then we'll talk. So absolutely, Beat, it's really important. And as those who've watched the video noted that I actually stayed on afterwards and carried on chatting with Kirsty for some time, and we talked about how she could do that, and because sometimes it is just simply spending time with somebody and recognizing that nothing is certain, nothing is set. So it's always worth exploring with the clinical team. What can be next? Have I got a formal diagnosis? Is that right? And that sometimes, particularly when people aren't feeling confident or they're still really low in their mood, it's having the confidence to ask those questions. So I do hope that she had come back to the team and asked them, because she felt quite comfortable that she was able to do that. But I think that leads us into some of the work that Sue and Sue's team are leading on about how do we not just reactively get people's experience, but building the proactive work so that people know throughout all of our services how to speak up, how to be listened to, and then how to enact that if you're not. And that's part of the on-site advocacy work, and it's building that through all of our services.
Thanks, Natalie. I've got no other hands showing. So thank you ever so much, Lucy and the team, for coming along today and explaining more about what you do to us, and also answering our queries and questions. It's clear that the service you provide is absolutely vital. And as a meeting that Robert and I was at yesterday, somebody described there can be nothing more important than bringing life into this world. And it's you and the team often are looking after the most vulnerable mums and potential mums once that life is just prior to and once that life is brought into the world. So the work you do is critical. And it's also worth me mentioning in relation to the colleagues you work with from our two trusts. Within our local maternity and neonatal services, we've also got Wye Valley and we've got Worcestershire Acute. They're both rated as good by the CQC for their maternity services. And I found out yesterday there are only 9 maternity services in the country rated good or better. And 2 of them are sitting within our own footprint, and colleagues that Lucy and colleagues work with probably on a daily basis in that liaison, because it's one big sort of network of look after mums and potential mums. So you do a fantastic job. Thank you ever so much. Could you please pass on our thanks to the rest of the team? You've heard colleagues, especially comments, especially from Vina this morning, who's been down and met both teams at Herefordshire and Worcestershire. Please make sure those comments get back, because we really do appreciate what you do. We really do. and recognise the work you do. And we saw it in the eyes of Kirsty on the video. She was, although she had some other things that perhaps could be done for her, and that's what Natalie stayed on the call to have a conversation with. She was really fulsome about her praise for her contact with your colleagues in the team and how they've actually helped her from some dark moments. So thank you very much indeed.
Thank you all for inviting us, and thank you for your lovely comments. It's much appreciated.
Thank you.
Thank you very much. Bye-bye now.
Bye.
Okay, and with that rather uplifting knowledge about one of the services that we provide, we move on to the Chief Executive's report. Robert.
Thank you, Chair. And I was just going to add, actually, I thought that was a really fantastic patient story, and I really like the format, Natalie. I thought we got some real depth out of having the video before, so maybe that's something we can pick up outside with. That's something we want to continue with. I thought it was really helpful. So anyway, thanks, Chair. I'll just turn to my report. As usual, I'll just pull out a few key points, some of which just assign posters to items that are on the agenda, but important to note nonetheless. So just starting at the top with the national ones, we've obviously got the piece there at the start that we had the final bit of planning guidance, which was really quite important. We're in a protracted planning round this time. We do have an agenda item a little bit later, which Sue and Denise will take us through, but clearly that's incredibly important for us and our system as we go into this year. Just a nod to the future. You're all aware Sue is leading on a review and a rewrite actually of our strategy through this year, which we're going to bring together by January of next year. We've got the DHSC 10-year consultation on the NHS Constitution. That and other things will be factored into that. But again, just a nod to the future there. Really important item at the bottom of that page, that's 39 on Diligent. That's about the reasonable adjustment digital flag, which came in for services from April. Matthew and team, obviously in conjunction with Lisa, doing work around that, but we are working hard to make sure we're compliant with that one. I'm just going to flag, this is probably more of something that we might pick up through risk registers and so forth, but I think everyone's aware that there's still outstanding really important issues around pay review body recommendations and so forth, both with our nursing and allied professionals, but obviously with the medics as well. So pay review recommendations there, it's just noting that we're going through a process. We still haven't had the outputs of that, but that's going to be an important one to watch as we go into the coming year. Clearly a really important item about the CQC rapid review into the concerns at Nottingham Healthcare, and we are working through that internally in terms of review and any learning, and obviously that will find its way through CQC and upwards if appropriate. Next one, I just wanted to draw out just technically just about segmentation for our trust, just to confirm we are segment 3. Some work's been going on around just clarifying criteria for how we move out of that, but that's work that's ongoing. Clearly that's all very much linked to our improvement plan, which I'll just touch on at the end. I did want to draw out the one around the mental health inpatient survey results that were published. So this is an independent survey that's commissioned by CQC. Matthew's going to pick that up a little bit later on the agenda, but clearly a really important survey and actually some encouraging feedback on some of our services there. But I'll let Matthew pick that up later. And the final one I wanted to draw out was we've got an update on the improvement plan at the end of the Chief Exec's briefing. I know, Mark, you're keen that we have this as a standing agenda item for the future, which we will do. So that will be a standing agenda item with a proper report. But we've got some highlights there of the work we've just been carrying through and completing. I think there's one point of accuracy just around the resolution policy, which is clearly really important, and maybe Elaine or Vina will pick that up a little bit later. I think at the moment we haven't quite signed that off, but we've had a good discussion about it, so that's probably to draw out. Lots of other activity going on around the improvement programme, and maybe Mark, if there's any particular questions, we can draw that out as we go. That's the summary I wanted to draw out for you, Mark.
Thank you, Robert. Just to expand that, I've agreed with Robert that every public board will receive an update on our improvement plan, but the update will be sort of focusing on the risks in the plan, the things that are lagging behind. It's sort of exception reporting rather than how everything is going. Obviously, the plan also goes to Q&S and workforce on a regular basis, but just to keep board topped up. That's what we do that. Robert, could you just say a little bit more? You mentioned that the strategy refresh will come to board for sign-off in January. Can you say a little bit more about the timings for when board will be more involved in discussions on that, please?
I can, but I think I'll draw Sue in to talk about that as the lead. Sue?
Yes, yeah, that's fine. Thank you, Thank you, Mark and Rob. So the work's already been progressing for some time now about the architecture. Rosemary, who's going to be coordinating the strategy refresh, my deputy, has been linking in with colleagues across the trust, both SDU and corporate, to just get a sense of how we want some of this to look and feel. We want to get into more engagement throughout the summer, with the first public talking about the strategy work so far coming in the September public board. We've got some time potentially in October for a more detailed discussion, and then we're looking for the final sign-off in January. Rosemary would like to meet with all board members individually, and then there are a number of groups that will work around steering the work very practically, and then an oversight group just checking in, which is likely to comprise of Rob, Mark, myself and Rosemary, and if others feel that we need to get a different composition, please do let us know. So we've got the overview and the timelines, we've got the architecture and principle, and now it's about socialising, are we broadly where we want to be, and then really using it as a way in which we can re-engage around the work that we're doing. There's lots in there that speaks to the improvement plan. So it also picks up the engagement work that Scott took to talk to the 700 staff. And we've also pulled through some of the early patient and carer voices, because that's going to be central to the next strategy that we sign off as a board. So a lot of work happening in the background, some time planned in for it to come to us all, and then there'll be the work that we'll do with you all individually.
Thank you, Sue. So Jill, that sounded like to me very much an October, quite a session for us collectively as a board to discuss the work that's happened over the summer period, bolting in that staff feedback and the important patient carer feedback. So that'll come through in October. Thank you. Janet.
Thank you. I wanted to ask a question about the reasonable adjustment digital flag, because I think, Robert, you said that there was work ongoing on this. And what I really was interested in is, when are we likely to actually be meeting the standard? And are there any implications around resources?
Okay. I think I'll probably hand to Matthew, if that's okay, Matthew, just to pick up on where we are with that.
Okay. And I'm sorry, I'm going to hand over to Lisa in terms of the digital flag question.
Yeah, thanks, Matthew. I think the restriction we've got at the moment is the system suppliers providing that functionality within the system. So Care Notes Advance have put that in, and that is now live. And we're working with EMIS at the moment to make sure that that's live with community teams and with neighbourhood care teams. So it's in process. Care Notes is there for the majority of our services. It is available, and we are starting to report on it. Community teams will come in the next month or so once EMIS releases that functionality within the system.
Thank you, Lisa.
Lisa, can I just ask about the services that aren't on either Care Notes or EMIS, please? Because presumably they have to do it as well.
Yeah, so all systems will have to do it. We've focused on the two main systems for the moment, as it's new functionality. Sexual health and dental, who are the other two biggest services, are both implementing new solutions. So that would be picked up as part of those tenders.
Thanks, Lisa. Any other questions or points of clarification with regard to Robert's report? Okay, I think you got away pretty lightly there, Robert, as a first report. But thank you very much for that information. Lots of good stuff in there. We'll now move on to our board assurance framework and Jill. But just to remind colleagues that further down the agenda, we do have an item on the risk management strategy, and the two sort of link together. So over to you, Jill.
Yeah, so board members will be aware of the significant amount of work we've been doing about risk management, and I think this still represents a little bit of work in progress. I don't think we're quite there, but what I've tried to do in terms of the presentation this time is a much clearer linkage between what are the principal risks that we are recording through risk registers, how they impact on the overarching risks, or how they link in with the overarching risks in the board assurance framework, and what are the plans that we're going to have in terms of making positive progress in reducing down the risks. The reasons I say that I don't think we're there yet is because what I want to do at the next committee round is for the committees that are responsible for those risks is actually attend the committee and be seeking confirmation from the committees as to, one, do they think that they're satisfied that the risks that they're seeing are at the right level that then should link in, because what you'll see is that we don't have some higher level risks for some of the overarching risks. And I'm not convinced that that's quite right, and I think we're still working through with risk register owners, both through SDUs, with corporate leads, and with directors covering off the ones in their respective portfolios as to whether we've got some of the higher or the risk escalating appropriately to be at the highest level. And so what I'd expect to see probably next time we come is that we will have a view expressed in the report from the committees. So if we take, for example, the one relating to health inequalities at mental health at the Joint Committee, a discussion there about we do have some risks on the risk register about health inequalities, but actually are they appropriately scored? And the areas that I think that we still need to do a little bit more work on, and this links in with business planning, is for each area, when we're looking at what the priorities are for those areas, actually have leads considered the risk of not achieving those priorities. And so that's not just about being reactive in terms of what are we managing and what are the risks emanating from issues that we're dealing with, but also looking prospectively as to what are our priorities in each areas and what are the risks of achieving those. And so the first part, which starts on page 50 of Diligent, I would expect to see that develop, and actually a discussion with the committees about the timeframes for those, actually a shift in the scores, recognising that these are obviously not going to be things, the overarching risks that are going to be immediately resolved. So that's work in progress, and I will be attending each of the those committees that are responsible at the next round to actually pick that up and have a very specific discussion with the committees. What we also then have is the board assurance framework, linking in with which risks we've got at the highest level. One of the areas on the risk management strategy, which is a change to the previous risk management strategy, is that risk can be escalated not just on the scoring. So previously, we would escalate risk just on the scoring if they reached 15 and above, whereas what we're proposing in the risk management strategy that's later on the agenda is that if a key lead, so for example John or Natalie for a clinical risk, or Elaine for a workforce risk, or the SDU leads for risks in their areas, felt that there was a risk that was scored at a lower level but was of significant concern and needed escalation, then we're building in a mechanism for that to happen. And so I'd expect to probably see, linked under each of the overarching risks in the board assurance framework, some risks the majority of which will be the higher level risks in terms of scoring, but some of those will also be risks that are being escalated based upon the judgment of the leads. And so that's how we're working through that. I don't think there was anything else that I was particularly going to say at the moment, because I do think that we're on a journey. I don't think we're quite there yet. Certainly from the discussions that we're having through the risk oversight group, it does feel as though we're having different discussions. And I know that other colleagues have commented about how SDU leads in particular are focusing at integrated governance meetings on the risk. It does feel as though we're moving forward. I don't think that this is something that we're going to always absolutely get right, but it's I think we are making quite significant progress. And I have picked up making sure that we've got a set of standing item metrics at integrated governance for each of the SDUs, particularly focusing on risk management. So we should be seeing that coming through as well, and then escalating up to committees. I was going to pause there, Mark, and happy to take questions.
Does anybody have any questions? And on your comment, Jill, about it still being work in progress, I think it will always be work in progress, because we'll always be looking to hone and improve our risk management and risk identification. So it should always be work in progress, to be honest. Anybody got any questions or points of clarification? No? Okay. I had one suggestion. Should we just call it that? I can see Jill smiling. As we're doing our strategic review across the summer, it strikes me that our strategic objectives, the main BAF risk that are potential to impact our strategic objectives, they should be part of that review. So it's sort of some link perhaps between Sue and Jill to make sure they're considered, because if we change our strategic, I wouldn't say direction, because we wouldn't do that, but our strategic focuses in places, I think our risks need to be looked at. So if you could ensure that's part of the work, Sue, Jill, I think that would be a useful thing to do. Okay, we're going to come round to discuss risk again when we get to item 15 on our risk management strategy. But for now, can we agree and approve the board assurance framework and high level risk register as presented by Jill at this moment in time? Yes, nods around the screen, so we can take that as approved. And a reminder that we will revisit right at the end of our meeting to check to see if anything else that we think we've discussed today should be brought forward, either on the risk review or the BAF, risk register or the BAF. Okay, thank you very much, Jill, which then takes us to Sue and the trust priority programmes. Sue.
Yeah, thank you, Chair. So again, this is a slightly new format. We, as a board, have signed off our priorities for 24-25, and we have matched them to our strategic objectives. And this paper then is picking up those that run through Programme Management Board. There are a number of other priorities that don't run through PMB. So in the next iteration of this report, you'll receive escalations from the ones that don't go through PMB. So you'll have a matching set of all board priorities, but then that critical focus then on areas that are running through PMB, because those are deemed to be the big ticket items that we've agreed we want to focus on for this year. So just to highlight some of the areas that I've either got additional information I feel like we need to draw out. So within community paediatrics, we're still working on defining the scope. That has been somewhat delayed because we had the SEND inspection, and that had to become the immediate focus for the service delivery unit. But we're working to try and ensure that we move that forward so that programme of work can start. The getting it right first time, we've done a reset because there have been some other areas which have come into the frame, most notably an inpatient bed strategy was expected nationally, and also the work that we've had to do to turn around and tie down some of the support that needs to go into the programme. There's been some changes in personnel there. So that's moving forward, and we're taking that to the Health Overview and Scrutiny Committee in Worcestershire in June. The other piece is Matthew picked up earlier that we've now had the new talking therapies, waiting time adjustments. So that will probably be something that will shortly come off the work programme, given the significant improvements we've seen around the pathways in that area. Finally, I wanted to just flag that the virtual ward rollout is still predicated on funding. So whilst we have that for the pilot, that continues, we can't move forward with that until we've got more assurance that we're going to be able to fund that from within the system. So I would welcome feedback, not necessarily on the gallery today, but if you wanted to drop me a line, this is trying to move into a much tighter way of reporting from PMB. We've had a PMO reset, and that's pulled through quite a different way of trying to provide assurance to us here on the progress against our major transformation programmes and priorities. So any feedback, welcome, and that's happy to take any questions.
Thank you, Sue. Any questions at all? Martin.
Yes, thanks, Sue, and apologies because I wasn't at the relevant committee meeting where this was discussed. But I just wonder, in relation to priority 1, why the assurance level is not applicable rather than at 0 or 1, reflecting the fact that actually they are our priorities. We have got to do something on them, but we haven't got there yet, rather than it being not applicable for an assurance level. And I don't want to lose focus by it being not applicable, rather than actually saying we're at 0 or 1 and we've got to get something going on that.
Yeah, very, very reasonable comment, Martin. You're right. We've sort of said it's not applicable because we haven't set the scope yet, but actually at that point it would be on 0, wouldn't it? So I'll adjust that.
Thank you.
Thank you, Martin. And if there's no other comments, there's one comment perhaps linked to Martin's in some way, and this is probably a comment for you, Robert, as the Chief Executive. When I looked at this report, great report, so exactly as we want, but quite worrying. These are our priorities. It's in the title. There are priorities, yet when you look at COMPEDS, scope still being established, GERF, review of approach, ARISE, barriers and problems, and these are our priorities. So can I ask, Robert, that we ensure we keep on top of these and make sure they keep the pace that we know they need, because they are our priorities. And I really do applaud your report coming forward, Sue, in terms of the honesty within it. I went and met your PMO this week, by the way, a small but vital team, really impressive individuals, and I'm really delighted that reset has happened and they got the staff in, because they underpin some of the key work in the trust. So, Robert, if I could just ask you to sort of keep your foot on the gas of these. These aren't priorities selected by Sue or the PMO. These were priorities selected by the gallery on the screen here. So we do need to ensure we keep on top of them. Okay, thank you for that. If we now move on to the operational plan submission, and that'll be somewhere between Sue, Denise, I expect Robert. It's been a turbulent year, hasn't it, so far, in operational plan submission. So over to yourselves. Thank you.
Shall I start, Robert, and then Denise? So we obviously spent quite a lot of time at our development session looking at the components of the system plan. So I wasn't professing to go into too much detail. We submitted on the 2nd of the 5th. We've already looked at the performance changes in terms of metrics for ourselves, mainly there in mental health and learning disabilities and autism. And we've already looked into the changes that are required as a system around the workforce trajectories and being able to monitor those. Denise can come in with more information on the finances, but we put in a break-even position. At the moment, our plan is still working through NHS England. It's yet to be accepted. So today, really, we're acknowledging where we are because we've got some further work to do. I would like to make the point, though, Mark, it relates to your point about pace and progress. That doesn't stop us from doing what we need to do. I think our parts of the plan are clear. We've got a number of metrics that we knew about and we're working through, and the transformation programmes that are part of ours, let's say frailty as an example, we're moving on with the work regardless. So the plan position has outlined where we need to go, and we've factored all of that into our own internal assurance and planning processes now. So Denise, did you want to come in around anything to the money?
Yes, thanks, Sue. So the money side of things, we've been working on this for a number of months. And we had 3 iterations of submissions. final submission went in on the 2nd of May, which was a break-even position. So just to talk about that, we did enter 24-25 with an underlying deficit, and I know we've reported that at Trust Board before, which was 3.2 million. Main driver of that was excess inflation, and we did have some internal cost pressures as well. So over the last few months, we've completed the contracting round with our with the Hereford and Worcester ICB, and we did get quite a lot of our cost pressures funded, particularly excess inflation. So that helped. So we have put forward a break-even plan. To deliver that plan, we've got an efficiency target of just 4%. That equates to about £10.9 million. The efficiency is made up of agency reduction, and that is a must-do that we have to do nationally. Traditional cost out CIPs, and there are some technical efficiency gains in there as well. Just a final point on the financial plan is we do have to submit a capital plan as well. So we've got a £15 million programme for next year. Some of it is nationally funded, which is our replacement EPR system. So the must-dos next year are the EPR. We're finalising Stonebow, which should finish in August next year. And then we've got 2 schemes that will span 2 financial years, next year and the year after, which is the mental health UEC and the MIU at the Princess of Wales in Bromsgrove. So quite a full detailed capital plan we have in train as well. That was all I was going to say, Chair.
Thank you, Denise. I was going to say, Robert, do you wish to add anything? Robert?
Yes, I was just going to kind of draw together because whilst this very much focuses on what we as a trust need to do, it's really hard, obviously, to separate that from what we as a system need to do. So just one point on the detail. I think Denise said Stonebow, August next year. It's August this year that we should be completing Stonebow. We have the some further works that we're doing there, but that's not the eliminating dormitory part. I guess that the part that everyone will be aware is that the money for our system is particularly difficult. Mark and I both attended the ICB board meeting yesterday, so we are still work in progress in terms of finalising the system plan with the national team, and there's likely to be some further work and iterations around that. I think the message is we are fairly close, hopefully, to getting to an agreement, but that's not there as yet. The key focus, though, really is we have a plan here that is largely complete. That there may be a few changes around the margins, but this is the plan we need to deliver. It's a very challenging plan, but I think we do have some absolute clarity. Obviously, at the centre of that, we have our improvement programme, which is fundamentally important, and then around that we have a number of really important projects and initiatives. EPR is obviously a really good example, but we've got some areas that we're aware of within service delivery, particularly from a national perspective. Talking therapies, dementia diagnosis rate are 2. I know a number of colleagues have raised nationally concerns around community paediatrics, and a variety of services there are there, and we're absolutely in the same position as many a system there, but that's an escalating area of concern. And then, of course, there's the finance that Denise has talked to, where we do have a break-even plan, but that is one that is going to take quite significant attention. We've got a great track record on that. We've got some really good colleagues that work incredibly well around that, but that isn't going to be an easy ask as well. So I think it's a good summary of where we are with the plan. And Mark, I guess it would be a good time for any questions from the gallery.
Do we have any questions from anybody, accepting that some of it is still work in progress, as Robert indicated. Janet.
Yeah, thank you. Yes, I feel that I need to ask this question because I know we've talked about this a lot anyway. But I mean, this morning, earlier on, we've heard about a service where actually the remit is increasing and they're having to deliver more with the same resources. And, you know, we're fortunate that they're an imaginative team and enthusiastic, and I have absolutely no doubt that they'll manage to do that. But I think that's replicated across the organisation, and the paper that we had around the priorities, you know, in a number of cases, the issue there is competing resources or not enough resource. So I suppose my question is around the fact that we've got a savings target of 10.9 million. How assured can we be that we're going to manage to meet that at the same time as delivering all the extra things we seem to have to deliver?
Thanks, Janet. So yeah, 10.9, 4%, you know, it's a lot. We've got a worked up plan. And as Robert said, we do have a track record of delivery. It's going to be tough, but we think it is achievable. And looking at the cost improvement plan, there's not much on there that except agency that should impact on the services, the operational services. So we've made that very clear that, you know, there's not much that the operational services need to do other than deliver the agency, which would be really good. So yeah, it's going to be tough, Janet. There's no denying that, but we do have a full worked up plan.
Little bit of crystal ball gazing for you there, Denise, for the future. How are you going to save 10 million? Sue.
Yeah, it's just to provide a little more context, Janet, around the competing priorities piece. There's no doubt that that's what we hear all of the time when we're out and about visiting as board members, and it's a reality for the PMO, for example, to have the right people around the table. So through the planning round, we actually went back and did a capacity capability check. So a number of priorities we've moved from this year. We just said for some teams, we really need, if we're going to absolutely deliver the key parts of the improvement programme, so culture, EDI, new approaches to risk and government, really bedding in processes, we're doing all of that. Those are must-dos for every team. So then some teams are able to absorb more change because they either are better resourced or the change is something they're already embarking on. So we went round and did that, and that's pulled out a number of priorities. The area where there's still concern is really children and young people. There's so much happening around that agenda at the moment. So they're doing further work to look at how they might be able to potentially phase out some of what they're doing throughout the year. And then the PMO will put extra resource in to wrap around them to do so.
Thank you, Sue. Robert.
Yeah, thanks, Janet. And the point about resource, whether that's human resource capacity, whether that's financial resource, whether that's a whole raft of other factors you could throw in. I suppose Sue's talked about there's a very real need for us to be really thoughtful about the prioritisation part and look where we can help ourselves, help the organisation, help our teams through that. I suppose the other part around that, though, kind of the financial part, just to draw that out, I suppose there's a couple of bits I'd say. Nationally, the efficiency ask is around about 6%. So as an organisation, we are getting some benefit of the good stewardship, I'd put it that way, the good delivery we've had in the past. That doesn't make it particularly easier, but I suppose contextually to add that. I think the other bit I would add in is we are still seeing, even in a challenged circumstances, targeted investment into some areas, which is great news. So the mental health investment standard still remains. There's still service development funding. So if we took some of the big priorities for this year, there is a significant investment going into talking therapies. even in the straitened circumstance we find ourselves. I think the other one we are having discussions with ICB partners, we are expecting some investment into our children's services to recognise the fact that actually demand has been significantly growing. That doesn't make it any easier, and I guess we have to marry that with the national expectations around a real hard look at productivity and what the opportunities are around that. Now, I know that's a fairly glib thing and easy to say, but that is part of what we need to do. So it's a bit about prioritisation. It's a bit about how we redesign and change our services to get the best out of it. And there is a little bit about targeted investment in there. So that does all add up to a really tough year, but I think it does add up to one that with the commitment and skills we've got, that we can find a way through that.
Thank you, Robert. A tough year ahead, basically. A couple of comments, if I may. Firstly, if I mention Denise, you mentioned capital, and just for board's awareness, I went to both the Elgar unit and Stonebow unit last week, one day after another, not only to meet the staff, but to see the building works, and they're all but complete at Worcester. I think a bit of paint was still drying, I think it's fair to say. And obviously due, as Robert said, in August. It's fantastic to see the improvements, both for our patients, obviously, but also the environment in which our staff working. And one of the pleasing things to note, and I mentioned this to Robert, is you can walk around either unit and they both have the same feel. We're in one trust, and whether you're in Worcester or whether you're in Hereford, where our two main inpatient mental health units are, they've got the same feel, they've got the same look, they've got the same finish, and I think that's it's testament to the design, the developer and the builders. So it's looking really good, although we're still get to fully finished at Hereford. And I think we moved. Did we move into the new ward yesterday? Because I knew we were due to move wards at Worcester, but it was subject to all sorts of complicated things. So I'm not sure if we managed to move in or not. Matthew's just about to tell us. Matthew.
No, there was some minor small snagging things, as there always are at the end of these type of programs. So we're due to move in on the 23rd now. Okay.
Thank you, Matthew. The other thing I was going to mention is, Robert, and I can't remember where it was in our agenda, maybe 2 or 3 places, but the dementia diagnosis rate. This is an ICS metric, but it does shine rather brightly, because we as an ICS have this as the worst metric in the country. And I say we because it's not a straightforward one partner. It's across primary care, it's across us, and it's across others. And it's about diagnosis. It's not a treatment and care of dementia patients. It's about the diagnosis rate. And we need to have some form of deep dive. And I've had discussions with Robert, and it's likely, Janet, that there might be specific examination coming through to QNS to really try and get under the skin of this. And I know we're pleased that John, our Chief Medical Officer, is now leading the charge on this on behalf of the integrated care system, because we all recognise that we need to, across the system, do something differently to make this metric change. And I know we do have trajectories in place, but I think it's incumbent upon ourselves, especially with the Mental Health Joint Committee in being, and maybe that's the place to look at it. I'm not sure, but we will be taking a deeper look at it to see how we can keep a better oversight and assurance of that. Robert.
Yeah, Mark, we'll continue to do that through Mental Health Collaborative and Executive, but we're going to do a briefing for board, I think next board, actually, just so that everyone's fully aware of that metric and what's comprised and how important it is.
Okay, thank you very much indeed. If there's nothing else on that, we can note that. And if there are any subtle changes that come about, notably around the finances, then Robert will naturally keep us informed. And I think we'll maybe be chatting about it this afternoon in our development private session. Okay, if that can be noted for information, and we move on to
Mark Carroll's.
My hand's popped up there. I'm hiding in the corner, I think. Yeah, really just to endorse that. And certainly as the Mental Health Joint Committee, we have picked this up as one of the things that we really want to look at. And I think we've instigated that look at this by this board so that we increase people's understanding. But I think it's also something of a template for that system working anyway, because there will be other issues that we're going to try and solve that aren't just down to the trust. So I think getting the dementia diagnosis rate stuff right is going to be really helpful. So yes, all the deep dives are welcome. And I think the conversation we had at the last collaborative meeting really triggered some of this, so I'm really grateful for those now taking that forward. Thank you.
Thanks, Carol. In good hands. Okay, if we then move on to Matthew, operational update, please, Matthew.
Okay, thank you. And as always, there's much more to cover than I can put in my reports, and I'll try and be brief. Just to note, we continue to experience some challenges to local acute mental health bed availability. Cause of this is we've still got large numbers of patients who are having extended delays to their discharges. It's above 30% at times. We understand the root causes for the delays. We've got good processes in place about that. We've also got some key roles that were vacant now recruited to. So we've got a new service manager in place for inpatient services and new patient flow manager who starts at the beginning of next month. Worcestershire County Council have been extremely helpful as well. They've supplied now a dedicated social worker, and we're in talks about them supplying another. But we still have key roles vacant in complex discharge facilitators and some of the patient flow team leads as well. There's still vacant posts. There's a recovery plan in place, which we're closely monitoring through integrated governance. As Mark's mentioned, since October, Hadley has been closed for refurbishment. So we've been undertaking redecorating, new windows and doors. So the new doors with the door top alarms, new garden furniture, and some revisions as well to some of the internal layout to create better spaces for patients. And we're able to tour this month with some of the board members, and I think we're all very impressed with the standard of the new accommodation. As we've previously covered, the opening has been delayed slightly for a week, just minor snagging issues, mainly to do with plastering of finishes and things like that. So nothing major, no barriers to opening next week. And whilst the unit's been closed, we've provided male PQ beds at Athlone Ward, and those patients will transfer across to Hadley when it reopens. So there's 6 patients to move across. And we're taking this opportunity to carefully review the future gender mix options for the ward. So that may be subject to further proposals once we've carefully reviewed that. Onto the CQC service user survey. So the CQC mandates that all providers undertake an annual survey of patients who are using community mental health services. It's a national survey with standard questions, not conducted by us. We have to use an independent provider for that. But when the report's published by CQC, it allows comparison between different providers. Good news for patients in Herefordshire and Worcestershire is that in all the question categories, local services scored above average, and our scores were some of the best in England about patients feeling they're well informed about medication management and that they were benefiting from engaging with talking therapies. These aren't talking therapies IAP services, these are new types of psychological services that have been provided for community mental health teams as part of the new community mental health framework. And we were among the best in England at involving carers appropriately in people's care, which again is very good news. We actually got the top score in patients feeling that they were supported with access to meet their care needs. So good news there, and the full survey attached as well. We've had a local special educational needs inspection. So it's a planned joint inspection by Ofsted and CQC working together. So that's an inspection of health, educational and social care services for children and young people from 0 to 25 with special educational needs. Conducted just in Worcestershire, so it's done local authority by local authority. Several of our teams were included, as you might expect, for children and across adults as well, because this covers up to 25 years old. And a report by Ofsted and CQC will be published. The due publication date is June, but as ever, sometimes these things can be delayed by process, so it may be July at this point. UCR updates, so just to draw board's attention to the improvement in emergency access standard times at Worcester acute hospitals. Good news for everybody in Worcestershire. We also received a visit from the NHS National Urgent Care team to our access hub downstairs at King's Court, and they highlighted the good system working and cooperation between system partners, ourselves, the acute and the local authorities. So I think that's enormous credit to Rob Cunningham's teams there. And we've returned our community hospitals to the ordinary operating bed base after the winter escalation periods. We're back now to summer running until probably about August. Thank you. Any questions?
Thank you for that, Matthew. I hope you're not suggesting that summer's going to end in August, because I really do hope it goes longer than that with the amount of rain and gloom that we've had over the winter period. Questions, Martin?
Yeah, thank you, Matthew. And it's very great to see a really positive service user survey. I just wondered what feedback or what celebration we've done with the community mental health teams to, give that feedback and actually, be very positive about it, because we're quite good at improvement plans when things are going wrong, but we're perhaps not so good about celebrating the hard work they're doing and the outcomes that they're doing to encourage them further.
Yep. So we have had some trust communications around this and specific communications and well done to teams as well. And what I would say it's I think a real testimony to the success of the new neighbourhood mental health team model, because the areas that we would have sought to address through the new types of teams are exactly the type of things that service users are telling us are much better.
Thank you, Martin. If there's nothing else, I can only echo what Martin has just said, Matthew. We naturally and rightly focus on the areas we need to improve, but when you read the detail of that survey to see where we are in relation to colleague trusts across the country, we have done incredibly well. And what that means is incredibly well for our patients that we serve. And I think we do really need to find a way of, one, saying thank you to those teams, because I know they've been through some turbulence, as you've said, with the introduction of the community neighbourhood teams. I know you've had some problems in getting staffing for those teams, and you've had to be quite innovative in your methods of trying to bring staff and diversify the type of staff we've had. So if there's anything more that you think we as a board, the chief exec, myself, should be doing to thank those staff, then please say, because that survey really does say good things about our staff and the services we delivered, and they should be congratulated in the strongest means that we can. And sometimes we don't have sort of very good means in a way, do we? And thank you just a little bit inadequate sometimes for the work that they've done, but please make sure it's passed on, and I'll have a conversation with Robert about how perhaps we can do a little bit more than that to recognise. And also in that, I wouldn't like to forget what you said about the UCR hub as well. Our UCR teams have been extremely effective since the start, and I know the hub is a new way of managing that and more, and to see an external team come in and give you the compliments they have around that, again, it bodes well for how we operate in our trust. So thank you to you and the teams for that. Okay, if we can note that report and then move on to National Staff Survey findings, and a really important piece of information that informs us and our action plans for the future. Elaine.
Thank you, Mark. So the report is presented for assurance. Now, this relates to the annual staff survey that we know the Trust takes part in yearly, and we are benchmarked against other mental health and learning disability trusts. And what it pulls out are the key themes that we should be looking at and these having a greater focus on. So the report summarises those key themes and also provides the action plan. So on page 140, I think, of right, I'm looking at this. There is a summary of the key themes that came out of our survey. Specifically, I'll pull out a few around personal development, about our staff feeling valued, team working, ownership of change. 4 key areas we've identified and pull all of that together, where we're focusing on the empowering of our leaders at all levels, supporting and developing our staff, enabling our teams to deliver high quality outcomes, and transforming the culture of the trust. There is also running alongside this the work that is part of our cultural transformation work, which including A Kind Life, the work we're doing around ED&I, and also the CQC feedback themes, which we've also captured, and picking out a couple of them: variation around managerial approach, opportunities for staff to be developed, addressing issues around morale and discrimination. And all of these have been captured within the action plan itself. So it draws together the feedback that we've had from the National Staff Survey, the outputs that we're also getting from our Pulse survey on a bi-monthly basis, and the quality of that data will improve as we continue to gain more information on a bi-monthly basis. This is pulled through into how high impact deliverables, which have picked out the key 10 areas, and what we're going to deliver, also the time frame that we're going to be looking at it, and what our intended outcome is related to those high impact areas. You'll see on the final page the things where we expect to make an impact is about our leaders, for example, having a greater sense of confidence and agency to act, because one of the pieces of feedback that we were getting was there was a variability in leadership and how staff experience that there is a sense of greater confidence in senior leadership, in describing priorities, and we're picking that up through the improvement plan as well. That staff are feeling a greater confidence about raising priorities through our freedom to speak up work, and that there is a better connectivity. So these are ultimately about us addressing, as I say, the feedback that we've had from CQC, but also the feedback that we're getting, rich data from our bi-monthly Pulse survey, but also the key themes that have been raised with us through the National Staff Survey. This is also a conversation that has taken place at our Extraordinary Workforce Committee meeting on the 22nd of April. So NEDs and colleagues involved in that committee have been apprised of this already, but happy to take any specific questions if colleagues have them.
Anybody have any comments or questions on the staff survey? No? Okay, I have a comment. It may even turn into a question as my mind works, Elaine, and I don't know whether it's yourself, Robert, Vina. I look at the high impact deliverables and I make the assumption that that is a summation of the action plan. I'm not seeing an action plan in its entirety. Is there something behind this, and how is that being looked at, was the question. And the other thing, if I could just give you the other one, is the time frames on it. I assume that's the time frames for the metrics having changed, not the time frames for the deliverables in place. So, for example, the new leadership and management development offers rolled out. I assume it's rolled out before the January 2025, and I think leadership improvement, leadership visibility improvement, etc. That happens before March 2025. It's just the metrics from the Pulse survey won't pick it up until then.
Yes.
So two parts to my question, please.
Yeah. So the date there are the end dates. If we take the leadership program as your example, the intention is we'll do a soft launch at the Senior Leadership Day in June. There'll be a pilot in July. It will start proper in September. So that's an example of that. And I think the other one you mentioned was the metrics. Yeah, was that the other question?
No, the high impact deliverables, page 143 of diligence, isn't what I would consider to be an action plan.
Yeah.
I was just looking for some assurance that there's something behind it, more detailed, who's doing what, when and where, and by what time, and that's being overseen by Workforce Committee.
Yes, by Workforce Committee. It also feeds into PMB as well through the ARISE programme.
Okay, thank you very much indeed, and I did see some nods from Vina there as well. So, does anybody else have any questions? Because this survey runs again, I think it's September it comes out, or the back end of September. So our staff will be entering a staff survey again. So we do need to make sure that any actions we've taken as a result of this survey are very clearly in the minds of our staff as we move forward to that new survey period. Vina.
Yes. Yeah, just to make the point that the point of that extraordinary meeting we had was to specifically look at the findings of that staff survey, because we know that ignoring that feedback would be a huge disservice to our staff, and actually in turn it impedes our ability to provide the best healthcare for our patients. So the two key questions we had a very lengthy discussion about was whether we're confident that our current programme of works actually addresses the core issues coming out of the staff survey. And if not, then we need to identify where the gaps are. And board will be aware that there are significant plans that are already in place. We've got the ARISE programme, we've got the improvement plan, and all the different work streams coming out of that. But there is a danger that we get so caught up in doing a list of actions and just being busy, that we can occasionally lose sight of what it is we're trying to achieve. And I think it's become clear that from that extraordinary meeting that whilst we've got comprehensive plans in place, we still need a sharper focus and clarity on exactly who is responsible for doing what by when. We totally recognise that. So there is more work going on that, because we want to be as laser focused as we can be, because we've got to see those trajectories change. So there's an absolute recognition of that.
Thank you, Vina. That's exactly the sort of assurance we're looking for as a board. There's nothing more important than looking after our staff, and so this underpins all that. So thank you very much. If we can note that report, and we're being asked for an assurance on that report as well. Elaine, is that correct? I've moved.
Sorry, I couldn't get my mute off. Yes.
Yeah. Sorry, you'll have to remind me.
Assurance.
Is it a level of assurance or just general assurance in general that you're offering?
Assurance in general that board are happy with progress, that we have plans in place. Yep.
Okay then, which I'm happy to do, but if we were giving it a 1 to 7, it would be somewhere near the lower end, wouldn't it? Because of the fact that it's in place and not delivered yet, and those sort of things.
Yeah.
So okay.
Yeah, we've said. Yeah.
Okay, thank you very much. If we now move on to Jill, and as we said earlier, the risk management strategy, and this will be for approval. Jill.
Yes, so you've got a number of papers there. We have the revised risk management strategy, which I'm bringing to board for approval. It's previously been through audit committee, and we had a couple of minor changes there. You also have the report from the Good Governance Institute, and which includes recommendations and the responses to those. The revised strategy, the major changes are set out on the front sheet, but board will recall that we'd previously had a task and finish group looking at our risk appetite statement, and the revised risk appetite statements included in the strategy. I think one of the really important area of focus over the next few months as we develop our trust strategy is about us much more explicitly thinking about our risk appetite when we are making key decisions, and board members will be aware that we had a specific development session focused on that, and I think we'll need to revisit that over the forthcoming months to make sure that the risk appetite statement isn't something that we review once a year when we look at the risk management strategy, and that it's actually something we use in our decision making. The revised strategy also sets out the changes to governance arrangements relating to risk management, and that's across both how we have oversight and compliance with risk management through the organisation, but also through integrated governance and up through the committees. The risk oversight group as well that will be providing assurance about compliance with the strategy. A key focus there is actually going to be about cross-checking with executive leads about making sure that we've got the right, whether it's the clinical risk, workforce risk, finance and performance, etc. And then the final 2 points are about the updating of training needs analysis. One of the key recommendations arising from the GGI work was that our more senior staff, those at team lead, service lead, ward manager level, were not always fully conversant with expectations relating to risk management, and we've incorporated them into training, which we're making progress on, and they'll be required to undertake training once every 3 years relating to risk management, and we're getting in place monthly sessions to actually address that. And then the final element, which actually I mentioned already, was that escalation of risk isn't just based upon scoring. So I think on occasions historically we have sometimes seen some perverse behaviours relating to scoring where people might score at a level so that it is seen by committee or board, when the evidence isn't always there that either the impact or the likelihood of risk should be at that level. But that's because people feel that they want it to be seen at a higher level in the organisation. And so, again, it's one of the recommendations from GGI that we have escalation of risk both based upon scoring but also professional judgment as well. So those are the main changes. I'm asking board to approve the risk management strategy. I think it is important to say that our internal auditors are planning an internal audit review in Q2 of this year to look as to whether we have embedded the recommendations made by GGI. So they'll be looking at how we're managing the risk escalation within the organisation and looking at how risks, how we undertake the governance relating to risk through integrated governance. And so that obviously will go through audit committee towards the back end of the financial year. But at this stage, I'm asking board to approve the strategy.
Thank you, Jill. Can I ask for any comments or questions? I know this has been through, I think this has been to audit committee, Martin, to check process and procedure. And I think there were some minor comments from that. Anybody else got any comments at all? Okay, Martin.
Yeah, it's just to confirm, it has been through audit committee and we've had it a good go. I just want to re-emphasise what Jill was saying around the risk appetite and making sure that is a living thing. And I think once we get through October, in terms of this refresh, I'd like to talk with the PMB about how we actively monitor our risk appetite against the delivery of the strategy and really assess whether we are actually fulfilling our risk appetite or our risk statement on an ongoing basis rather than a policy document that sits somewhere out of sight. Are we taking enough risk to deliver our ambitions, or are we taking too much risk in terms of delivering our ambitions?
And I think you'll be pushing a very open door with the PMO, having met them this week, Martin, to that type of discussion. I think they would very much welcome that. Robert?
Yeah, thank you. I guess it was my question really is, whilst the strategy is a really important part of it, I think what a key question or a key issue that was raised was that it's about how well the organisation understands and follows that. So it's really important that we've got this, and I'm fully endorse what we've got here as a strategy. But I guess it's in terms of the improvement we need to make, I mean, Martin's referred to living the risk appetite part, but I guess it's just the actually how we've got on, Jill, with taking this out and embedding this in our new arrangements. Perhaps you could just expand on that part a little.
Yeah, so we have been, myself and Jane Freeman, the Risk and Security Manager, and Tori Annis, who's the Patient Safety Manager, has now we've done the first round of all the meetings with the SDU leads and their deputies. And actually what that's led to is a number of invites back to talk to, in each SDU, their senior leadership team, as part of the cascading of the framework and how to use it. And so we're using those meetings, one in terms of raising awareness, and I would expect after board approving this that I would expect to be issuing something through comms to push that wider out. But I think we are starting to see some changes in practice. I don't think we're fully there, and as I said earlier, it feels a little bit like the Forth Bridge in terms of rolling this out. But I think we are starting to see through operational services a greater understanding. And I see it as being absolutely critical at the local integrated governance meetings for those discussions to be taking place and people to understand what we're looking at, and when we're questioning scoring, that the purpose of that's not about trying to stop things from escalating. That's very much about understanding how people have reached the level of scoring, and if that's based upon evidence. So, for example, whether it's incidents or complaints or litigation, so that we have a proper basis for consistency across the organisation. So I think it will be one of the areas that I'll be looking to report on, I think, back to audit committee, about how we're making progress with the training, and actually as well whether we're seeing evidence of the principles being implemented in action. So I would expect to be seeing that reported through audit committee, and the risk oversight group has a standing item on that agenda.
Thank you, Jill. John.
Jill, on page 210 of diligent, or 209, it says draft risk appetite statement. What is the status of that statement? Because in terms of the regulatory risk appetite, we might need to have some further conversations around stating we have an open risk, and I would like a bit more detail on what sort of regulation are we talking about. I mean, I think professional standards talked about here, but you've got quality regulation, financial regulation, and so forth. Because if we are saying that we are cautious on quality, I'm unsure how we can say we are open on regulation of quality, which is around basic standards of care.
So page 210 is the GGI report that I've included that for transparency, in terms of that includes the work that was done by the Task and Finish group that we'd previously brought to board. That's been incorporated into the strategy in the main strategy document. Just in terms of the regulatory, I think what we were trying to demonstrate there is actually at times that we will be, clearly we need to have to demonstrate compliance with regulations, but actually that if we feel that we've got a sound evidence base for actions that we're taking, that we may on occasion push back on that, because if we believe that the actions that we're going to take are appropriate, That's why we have suggested an open appetite for regulatory risk. It covers all types of regulatory risk. Obviously, we have different regulators, whether it's quality of care, whether it's health and safety, whether it's NHSC, etc. But it's not just about looking at the regulations in themselves. It's also sometimes, why are we making decisions, and do we think that we're not going to passively accept just what regulators may say? And that was why we'd suggested the open appetite there.
Thank you. So is that the final risk appetite statement,
so that's
or draft?
That was the draft that was in the GGI report, that and that's been incorporated into the strategy. Just going back to check which page of the strategy it deals. That's on, but the page that you've referred me to there is part of the work that GGI did with the Task and Finish group of board.
Jill, can I suggest that incorporating the GGI report here is great for openness, transparency, but I think it could cause confusion if you're suggesting it should be part of our published risk management strategy. You're not suggesting that, are you?
No, I'm not suggesting that. I'm suggesting I've incorporated it here so that the board has publicly received the GGI report and the response to that. But separately, the risk management strategy is a trust document, and that is what I would be anticipating communicating to the wider organisation, subject to board approving that today. But the GGI report
is our risk management strategy. Sorry, is our risk appetite statement? I've read it, but I can't remember where. I've obviously read it lots of times, but I've read it in these papers somewhere. Is it part of the strategy as presented today, outside of where it is? Could you give a page number, please, if you can find it?
I'm just desperately going.
That's what I've been trying to do as well.
I think it's on page 8 of the strategy. Just bear with me. It starts. It 174 of diligent. Oh, it might be one. Sorry. I think it might be.
Yes, it's
page 169.
169.
Yeah.
Okay, so that would be our risk appetite statement. And so the pages to which John refers to are merely the report from GGI for information and for us to publicly receive it in a transparent way.
Yes, that's correct.
And again, this whole subject matter, some would call it a science, but it's definitely not an exact science.
I would say more of an art.
Yeah, it's a great example of the paper can say one thing, it's how it's used, and the question that Robert asked and how Jill answered it, how it's used and used within the organisation to change our practices for the better is the key thing. Because we're going to be asked to approve this policy now. And so, John, I want to make sure that you're cognizant of our risk appetite statements starting on page 8 of the 36 or page 169 of diligence, and you're comfortable with what that says. Again, remembering it's not an exact science. Are you comfortable with that, John?
Yes, I am, Mark. Like I said, this is a dynamic statement, so we can amend it. I think the way Jill explained the regulation side, it's much more clearer now. Thank you.
Good. Thank you very much. So, board, can we approve that policy, please? Yes, all round. Jill, thank you to you and the team and whomever else behind the scenes. I'm sure there are plenty of people on this screen and elsewhere. It's not the most dynamic of subjects in many people's minds, and for you to encourage me and get me to attend at least 2 or 3 meetings about risk appetite statement, and then to agree with such a thing and actually publicly trumpet it, you've obviously done a good job at this. So thank you, and thank you to the people that have worked on this. It's a part of the underpinning foundations of what we do and why we do it. So it is quite important, but even more important that we use it properly. So thanks, Jill. All approved. Well done. Which then takes us to a break, folks. And I don't like to worry you, but we're we're actually 4 minutes ahead of schedule, so I don't want you to start getting giddy. But shall we say we come back at 11:10, please? 11:10. Thank you.